So thank you all for having me. I'm excited to be here. My name is Kamdar. I'm a staff physician at Mass General Hospital. We're going to be talking today about parenteral pain management. And before we do that, I'll just introduce myself a little bit more. I've got a little bit of an atypical background. My training is actually in internal medicine. What I'd like to say is, despite being an Indian male in internal medicine, I did not go into cardiology. I fought the genetic impulse, and my parents still talk to me. But I fell in love with palliative care as an intern, it just really spoke to me. But I always liked using my hands, and I always liked minimally invasive procedures. So I wanted to be able to do interventions for my patients if they had refractory cancer pain, like they needed a nerve block or an intrathecal pump. So I snuck into an anesthesia pain fellowship, and then stayed on staff at Mass General, dividing my time between anesthesia pain and palliative care with the clinical and research focus on refractory cancer pain. So we'll talk first about parenteral pain management, and then later we'll actually talk about one of the areas that is near and dear to my heart, which is interventions for refractory cancer pain. So before we get started, I don't have any relevant disclosures for this talk. I do sit on the scientific advisory board for a startup company looking at trying to develop new targets for cancer pain. We have a lot of ideas. We started this with friends, but we have no funding. So if you see a Porsche parked outside, I can assure you it's not mine. I took the subway over here. So really what we want to do with today's talk, we want to give you guys a sense of why parenteral pain management is important. We're going to talk about when to think about it, and practically we're going to talk about how to use parenteral pain management. We're going to talk about transitioning to and from parenteral pain agents by discussing routes of administration. We'll talk about the indications, the advantages and disadvantages of each of these routes. Again, we'll talk about transitioning to and from parenterals. And then we'll try to give you guys some concrete recommendations for doing this successfully. Okay, so we'll just put this into context. You guys that are in palliative care don't really need me to go into much detail here, but to know that pain is a significant problem for many of our patients. I think the public has a pretty decent knowledge of how cancer pain impacts patients. We know that patients with advanced cancer, 70 to 90% of them will have moderate to severe pain. But one thing that the public, and I think a lot of our colleagues underappreciate, is how our other palliative care patients oftentimes suffer with pain. For example, 85% of patients with heart failure will experience moderate to severe pain, and around half of patients with advanced lung and renal disease will also suffer pain. And one of the challenges here is people oftentimes don't think about it and don't pick it up, much less treat it. And we also know that when pain is untreated, it then has a ripple effect for our patients' family members as well. So being savvy with being able to use parenteral pain medications is helpful not only for the patient, but also for the ripple effect that it then has on people around them. So the good news is that for most of our patients, using systemic agents, we can control their pain, right? And commonly, we oftentimes use oral routes. In the hospice setting, the rectal route is common. And there are other times that we use routes other than the oral and rectal route. Again, those are the enteral routes. Sometimes we use transdermal routes, which is a parenteral means. But we're going to focus specifically today on other parenteral routes, primarily intravenous, subcutaneous, intramuscular for this talk. And in the next talk, we're going to talk about epidural and intrathecal delivery. Again, because the important thing is that there are going to be certainly times and frequently where these routes are unavailable or less than ideal for what's happening in front of you at the bedside. So when do we think about parenteral analgesics, right? Well, and we're going to focus here on intravenous and subcutaneous. And generally, we think about them when the oral route or the rectal route is unavailable, or if it's really kind of less than ideal, meaning that if someone's having severe or acute pain in front of us, using those types of routes may not be the best from a pharmacokinetic standpoint, and we'll talk about that. The reason that these agents are helpful in the acute setting is because the onset is rapid. IV is going to have 100% bioavailability. Subcutaneous delivery is actually pretty equivalent to IV in terms of potency. The pharmacokinetics are a little bit delayed, but certainly faster than oral. And using either IV or subcutaneous allows us to both provide basal analgesia through a continuous infusion and also be able to treat acute episodes of pain on top of that with breakthrough dosing. Okay. The disadvantages to these routes are they're more expensive, right? And cost can certainly be an issue in healthcare as a whole, but particularly when we think about the hospice setting. It does require trained personnel to place these types of access and to care for them. And oftentimes at home, it involves having good caregiver and family involvement to be able to maintain these lines of access. So now let's talk specifically about intravenous. The good thing about IV delivery is that it works quickly, right? So the onset is 5 to 10 minutes. The peak effect is generally within 15 to 30 minutes, usually closer to 15, as Dr. Reedy mentioned in her last talk. And this allows us to rapidly titrate. Oftentimes we can keep bolusing with IV meds every 10 to 20 minutes if needed at the bedside. The duration of the site is variable depending on what kind of line you use. So a peripheral line is going to be accessible for a few days, whereas PICC lines are used for longer term access for several weeks. The disadvantages with IV is that you have to have the ability to access the venous system, right? So if someone has, for example, a patient with dialysis, they may have limited vascular accessibility, and just the process of placing a longer term line may or not be something that a patient might be interested in. And then there's issues of maintaining patency, right? So we need to think about things at home like saline flushes, heparin flushes. And aside from that, for our patients who are on hospice or are undergoing end-of-life care, thinking about the volume load that comes from just a simple KVO. Doesn't seem like a lot per hour, but over time that can actually lead to a fair bit of intravenous volume. Obviously the risk of phlebitis and thrombophlebitis with IV, and there's a greater risk of bloodstream infections with IV. And patients, particularly oftentimes if they're in the hospital, they're tethered to IV poles. At home, they're tethered to their PICC line. And so that can be an issue when we think about quality of life. Now let's talk about subcutaneous delivery. The onset here is also pretty quick, 10 to 20 minutes with peak effects around 30 to 60 minutes. One of the nice things about subcutaneous delivery is that we can oftentimes just use a butterfly cannula or a button, which is sort of like almost like a thumbtack that can be applied subcutaneously. And these can be removed. Oftentimes they can be left in for a week and then removed. So it does allow a little bit of greater mobility for our patients. Placement is thought to be associated with less pain than having to try to find a vein to place an IV catheter. These are also thought to be safer in the sense that there's a less risk of bloodstream infection. Certainly you can have cellulitis from these types of placement. And overall, again, when we think about cost, these are felt to be more cost-friendly when we think about, again, the costs that go into maintaining an IV line. Okay, so this is, I think, probably the biggest disadvantage to subcutaneous delivery is that at most, when you factor in both continuous and bolus administration, that you're limited to around 3 to 4 mLs per hour subcutaneously in terms of absorption. There also can be localized pain with subcutaneous absorption, so methadone is a classic offender for this. What people find, though, is that using 0.5 milligram to 1 milligram of dexamethasone per day mixed in can actually prevent that type of localized pain. But there can be other local issues, for example, inflammation, infection, necrosis, pruritus, and then leaking if there's not a lot of subcutaneous tissue. And certain medications can't be given subcutaneously, and so that's another limiting factor when we think about subcutaneous delivery. So why do we think about parenteral agents when pain is severe, right? And this is kind of intuitive to a lot of us, but I think it's important to have an understanding of the pharmacokinetics, and that's why I like this chart. So when we think about oral agents, say, for example, morphine, the onset when someone's given a dose is around 30 to 60 minutes with a peak effect in 60 to 90 minutes. The effects generally last sort of 3-ish hours, which means we can titrate usually at the earliest every 2 hours, so Q2-hour dosing. Whereas sub-Q is faster, right? The onset is in 10 to 20 minutes, the peak effect in 30 to 60 minutes, and it can be titrated every 10 to 20 minutes. IV even faster, 5 to 10 minutes with the peak effect in 15 to 30, and allows us to titrate sort of in 10 to 20 minute intervals. And so what that means is using parenteral agents, we can have quicker onset, and then we can titrate quickly if that initial dose that we give is not effective. So intramuscular injections, problems with this. One is that the pharmacokinetics are very, very unpredictable. Besides that, it's painful to place an intramuscular injection, and it can also be associated with fibrosis and abscess. So in general, we try to avoid IM delivery when we can. All right, so let's go through a case here. We'll talk about patient NPO, who is a 56-year-old male with metastatic colon cancer. He develops new nausea and vomiting and severe abdominal pain. He's admitted to your hospital with a likely SBO. He's on a significant amount of non-parenteral opioids at home, and he's writhing in bed in front of you in a severe pain crisis, in part because he hasn't been able to keep his home medications down, right? Not an uncommon scenario. You guys have probably seen this in your practice multiple times. So the team calls you to help, and they want to know, well, how do we convert his home regimen that he was already on to parenteral? And then on top of that, how do we get this poor guy who's writhing in pain in front of us, how do we get his pain under control ASAP? So there's two questions, I think, for us to consider here. One, how do we replace his basal opioids in a parenteral delivery, right? Because if we don't do that, if we don't make an adequate assessment and do a good equianalgesic conversion, we're already going to be behind the 8 ball because we're not already replacing what he was on at home. The second is, in order to get his pain he's having now acutely under control, we need to think about identifying an effective breakthrough dose, and we'll go through these in detail. So first, let's talk about replacing his home regimen now that he's not able to take orals. So we're going to talk about converting to a parenteral basal rate. So once we've decided that we're going to pursue a parenteral opioids, we got to think about how much total opioid are they on in the last 24 hours, okay? So we're going to take what they're using in extended release, what they're using in immediate release, and perhaps if they're on a transdermal fentanyl patch, we're going to factor that in as well. And then once we've added that up, we're going to determine the equianalgesic total 24-hour opioid dose, okay? So let's go through some examples. What we're going to do is with these different scenarios, we're going to convert to an oral morphine equivalent, and on the next few slides, we're going to convert to IV morphine equivalent. We're using morphine here just for ease of examples, okay? But certainly you're not tied to using morphine. So in scenario A, patient NPO is on long-acting morphine, 45 milligrams every 8 hours, and he's using 15 milligrams of breakthrough, which in the last 24 hours, let's just say he's used 4 doses. Okay. So 45 times 3, right, because he's on Q8-hour dosing, is going to give us 135 milligrams of long-acting morphine in the last 24 hours. And 4 times 15 to get his amount that he's using in breakthrough comes out to 60 milligrams. If we add those two together, we're looking at 200 milligrams per day of oral morphine equivalent, right? Let's do a little bit more of a complicated scenario. We've got a gentleman here who's on OxyContin 100 milligrams every 8 hours, and he's using oxycodone 30 milligrams, 3 doses in the last 24 hours. He wasn't using more because he wasn't able to keep it down. So in terms of his OxyContin amount, he's using 100 milligrams times 3 doses in the last 24 hours, which would be 300 milligrams, and 3 doses of the 30 milligrams of oxycodone. That's going to be another 90 milligrams. So if we add that up, and we think about converting from oxycodone to morphine, the conversion ratio here is 2 to 3. That's going to come out to 450 and 150 of oral morphine, respectively, in terms of long-acting and then short-acting equivalents, right? But that total is 600 milligrams, but remember, you guys probably talked about this yesterday, when you convert between opioids, you're going to be partially tolerant, but not entirely tolerant to a different opioid. And when that happens, you have to account for incomplete cross-tolerance by reducing by 25 to 50%. So let's just hedge our bets and reduce by 1/3 for incomplete cross-tolerance, and that's going to come out to 400 milligrams of oral morphine per day. Make sense? Okay. So scenario C, this patient is on hydromorphone, 8 milligrams. He's using 12 doses in the last 24 hours. So he's using it every 2 hours for severe pain. That comes out to 96 milligrams in the last 24 hours of oral hydromorphone. The ratio here from hydromorphone to morphine is a 1 to 4 conversion. So that comes out to almost 400 milligrams of oral morphine equivalent. Okay. Fentanyl is what he's using for long-acting, and he's using 4 100 microgram patches. And so that comes out to 400 micrograms in total. And the conversion here is 1 microgram of fentanyl is equal to 2 milligrams of oral morphine. This is generally the conversion that we use. If you look at the manufacturer's conversions, it's a bit more conservative. We generally use a 1 microgram to 2 milligram of morphine conversion. And that comes out to 800 milligrams of oral morphine equivalent. So adding these two together, we're looking at 1,200 milligrams per day of oral morphine, so over a gram of oral morphine. Again, because we've gone from hydromorphone and fentanyl to morphine, we have to account for incomplete cross-tolerance, and we're going to reduce by 1/3 So that comes out to 800 milligrams of oral morphine equivalent per day. Okay? So in these different scenarios, we've added up their 24-hour oral morphine equivalent. Okay? And once we've done that, then we're going to divide by 3, because it's a 3-to-1 ratio from oral morphine to intravenous morphine, to figure out how much total intravenous morphine this patient would be using the equivalent of in 24 hours. Okay? Once we've done that, then we can divide the dose by 24 to figure out how much to give per hour, what the hourly rate is, and then we can administer that via continuous infusion. Okay, so let's go through those different scenarios. So patient A, if you recall, was taking 200 milligrams of oral morphine equivalent in the last 24 hours. So if we divide that by 3 to get to IV morphine, that comes out to 67 milligrams. Okay, and now we have to divide by 24 to figure out the hourly rate. Okay, so that's going to come out to roughly 3 milligrams per hour. Make sense? Yeah, okay. So let's go to a patient who's on a higher amount. So 400 milligrams of oral morphine equivalent. Again, we're going to divide by 3 to get to the IV formulation, and then divide by 24 to get the hourly rate, and that's going to come out to 5 to 6 milligrams per hour. In scenario C, this patient's on 800 milligrams of oral morphine equivalent over the last 24 hours. We're going to divide by 3. That gives us 266 milligrams of intravenous morphine over 24 hours. We'll divide by 24, and that's going to give us around 11 milligrams per hour of intravenous morphine. I put a little asterisk there. As we start getting up to higher amounts of morphine per hour, we oftentimes, even though there's no ceiling dose for opioids, we generally can start to see some signs of opioid neurotoxicity. So it's not unreasonable to go to a more potent agent that might require a lower dose. All right, so you've done a good job. You figured out how to convert what they were using in basal analgesia at home in their oral regimen to an IV regimen, but now we have to get this patient's pain under control now, right? So we need to figure out what dose is going to be effective to bring his pain under control in the short term. So let's take a second to talk about the dilemma of the drip. So why is relying on continued adjustment of a continuous infusion less than ideal to control pain acutely? Like I remember in training, a patient would be made CMO, and that sort of meant to the team that it was time to commence morphine overdose, right? And they would write an order for 0 to 40 milligrams per hour on a morphine drip and titrate to comfort. And the problem with that is that, you know, the patient might have some dyspnea and pain, and they'd start at 2 milligrams, and that didn't work. And so 30 minutes later, they'd go up to 6 milligrams, and then 30 minutes later up to 10 milligrams, and still not seeing relief. And the problem is that when you increase a continuous infusion by 4 milligrams, remember that's 4 milligrams over the course of an hour. And that is not going to, you're not going to see that effect pharmacokinetically in terms of reaching steady state for several hours. And so that's the problem with using just a continuous infusion and continuing to titrate. Rather, it's much more effective to use bolus dosing up front and then use how much you need in a bolus dosing over X amount of time, and we'll talk about this in a second, to then adjust the continuous infusion, okay? So using bolus doses first to get us into a therapeutic window that's going to help a patient, and then think about having that continuous infusion sort of carry us forward beyond that, okay? So now, again, when you're using bolus doses, if someone's opioid naive, it's generally thought to be safe to use 2 to 5 milligrams IV or the equivalent in another opioid. If they're opioid tolerant, they're coming in already on an opioid regimen, you can use 100 to 150% IV equivalent of whatever they're using in home breakthrough and start at that dose. So if they were on oxycodone, convert that to morphine or hydromorphone and use 100 to 150% of that as a starting dose. Or you can calculate their 24-hour total opioid use in IV form like we just did and start with 10 to 15%. People do it either way, okay? What happens next really is going to depend on what the response is to that initial dose, okay? So you decide on a dose and you give it. You can reassess generally within 15 to 30 minutes. This says 30 minutes, but it's not unreasonable, again, because the peak effect of an intravenous opioid is going to be around 15 minutes. You can think about redosing after 15 minutes. And so generally one of a few scenarios happens. If we see no pain relief and no side effects, you can increase that dose you just gave by 50 to 100%. So if you gave 2 of morphine, you can give 4 of morphine. If you see partial pain relief, say that patient's pain goes from a 10 to a 7 and no side effects, well, now you're playing with a little bit of fire, and you can give that same dose again to try to knock it down further, okay? If you see good pain relief with that initial dose, well, you've identified your breakthrough dose, and you can think about starting a PCA, patient-controlled analgesia, with that initial dose. And if you see no pain relief and you start to see side effects, this is where it gets a little tricky, right? Someone gets a little sedated with your initial opioid, but they're still reporting 10 out of 10 pain, right? Your therapeutic window starts to narrow a bit. And so generally when this happens, we think about switching to a different opioid because you've kind of reached the upper limit dose for the opioid you just gave. But one of the other things that I think is really important to think about, we get so fixated on the opioids that we forget about the adjuvants. And so when I'm working with one of our palliative care, one of our pain fellows, when we're heading to see a patient who's got a pain crisis, as I'm thinking about, well, what IV dose of opioid am I going to start, I'm going, is there a contraindication to ketorolac? Because it can be markedly helpful for pain crises. You're not going to see sedation with this, but you are going to see opioid-like analgesic benefit, and that can help widen that therapeutic window, again, when things are getting a little tricky and you're seeing ongoing pain and sedation. You have to be careful if someone's got a history of GI bleed or gastric cancer, if they've got low platelets or renal insufficiency, but this can definitely bail you out when you're in a tight situation. Decadron can also be helpful. It's a potent anti-inflammatory, as many of you know. We use it commonly for cord compression, head pain from brain metastases, et cetera. You know, steroids do come with side effects, and so you have to weigh those. But both steroids and ketorolac can be very helpful for bone pain, for pain from hepatic metastases or in lymph nodes where there's visceral capsule stretch. So just remember to think about those. One of the things that comes up relatively commonly is questions about intravenous acetaminophen. The best data from this really comes from the post-operative literature. It's used for moderate to severe acute pain in doses of 650 to 1 gram IV. The onset is quick, 5 to 10 minutes, the peak effect around 15 minutes. Seems to be best used for acute pain control. It's unclear if this reduces opioid consumption. Seems to perhaps reduce some nausea and vomiting, again, in the post-operative setting. But it's super expensive, and we rarely use intravenous acetaminophen in our practice. So just something to know about. All right. So let's say we've gotten our patient under control, and we want to start them on a PCA. PCAs can be really helpful for rapid control of pain. Once we find a breakthrough dose that's effective, you don't want to just slap somebody on a PCA and hope that it works. You want to think about, well, what's the breakthrough dose that I need to get this patient's pain under control? And from that point backwards, then start a PCA. It can be really helpful to assess what someone's 24-hour opioid requirement is. So you start someone on a PCA overnight, you come in the next morning, you can extrapolate, particularly if they're comfortable now, how much opioid did they need over that 12 hours to get their pain under control, and then you can figure out, well, how much do I need to put into either continuous infusion or a long-acting oral opioid to maintain that degree of relief. It can be really helpful for incident pain. For example, a little old lady who's got a hip fracture whose pain is quiet when she's at rest, but as soon as she moves or works with PT, her pain gets bad. It can be helpful for using a dose of that prior to activity. And the data suggests that there's better pain control and patient satisfaction with PCAs. I think there's also an element of giving patients a sense of control that can be helpful. And we don't see increases in opioid-related side effects, so we oftentimes coach patients. They oftentimes worry, am I going to overdo it? And we talk about the safety profile with PCAs. You do want to be careful in patients that are delirious. If there's an overeager family member who might be rapidly pressing the button, family members oftentimes use the PCAs for patients in the hospice setting. In the hospital setting, that can be a little bit tricky. And in patients with concern for addiction, obviously you want to treat their pain adequately, but just be careful about tipping towards flaring their addiction. So there's 4 factors that we think about with opioids, 4 parameters. One is, what bolus dose are we going to start with? And there's different ways one can do this. One is to take 25% of their hourly IV dose, now that we've determined this, and set that at Q15 minutes, or you can go higher and do 50% Q30 minutes. Some people do 10% of the 24-hour dose divided by 4 and administer that every 15 minutes as needed. I generally, again, try to figure out, well, what dose is going to be effective, what breakthrough dose is effective, and kind of use 50 to 100% of that. But I run the numbers different ways, and I just kind of think about what makes sense. In terms of lockout, you want to set the lockout long enough to see the effect of the prior dose, both in terms of analgesic benefit, but also side effects. So when I'm using things like hydromorphone or morphine, I generally set a lockout of 15 minutes because that's when we'll be seeing the peak effect. For fentanyl intravenously, which has a quicker onset, but a peak effect that happens sooner, I might set the lockout at 10 minutes. And then depending on your institution, PCAs oftentimes come with a 1 or a 4-hour maximum. One thing I'll just say about this is people sometimes forget about the continuous infusion, and a lot of PCA pumps factor that in. And so they'll increase the pump the next day and forget to increase the 1 or 4-hour max, and then patients might run into a ceiling in terms of how much opioid they can get. And then we talked about calculating the basal rate if you're going to start one for a patient. So one of the questions that comes up is if a patient comes in the pain crisis, they're opioid naive, can I start a basal infusion for them? And so the answer is yes. And what you can do is when you're using those bolus doses to get them under control, you can figure out in backtracking and figure out, well, how much do I need to start a continuous infusion? So I'll just take you through an example. If a patient is using 4 milligrams of IV morphine over the last 4 hours to get their pain under control, so maybe you gave them 1 milligram IV, then another 1 milligram IV, and then 2 milligrams, and now they're feeling comfortable, and that was over the course of 4 hours. So if you calculate that out, that's going to be 24 milligrams over 24 hours. And we can take, as I mentioned, 50 to 100% of that and put that into a continuous infusion. So we'll have a 0.5 to 1 milligram per hour continuous infusion. Likewise, we can do the same thing for someone who's already opioid tolerant, who might already be on a basal rate. So, for example, our patient NPO, we made a calculation of starting a basal rate based on what he was using before. And let's say he needed 12 milligrams in breakthrough bolus dosing to get his pain under control over 4 hours. So that comes out to about 3 milligrams per hour, and we could take 50 to 100% of that and add it into that continuous infusion we calculated a few hours ago. So I think one of the key pieces is that continued titration with our patients is really key to being successful at it. So you want to stay on top and keep readjusting during the course of their pain issues. So our patient NPO, let's say you come in the following day, now he's using 48 milligrams over the last 24 hours in bolus dosing through the PCA. Okay, we can take 50 to 100% of this and put this into their basal continuous infusion, just like you might in clinic where a patient's coming in on OxyContin and oxycodone. You might take what they're using in breakthrough oxycodone, take 50 to 100% of that and put it into their OxyContin. We can do the same thing parenterally. So for this patient who's using 48 milligrams over 24 hours, 50 to 100% of that is 48 milligrams is going to be 24 to 48 milligrams. We'll divide by 24 hours to see how much to increase the hourly rate, and that allows us to increase NPO's hourly rate by 1 to 2 milligrams per hour. Okay, makes sense? Yeah. All right. And obviously you want to continue the PCA bolus dose or adjust it if need be. If it's not effective, you want to make sure that dose is adequate. So then the question is, you've got a patient's pain under control. When do you switch back to orals? And it really comes down to, is the oral route reliable? Can you use it? If you can, you're going to take 50 to 100% of their 24-hour IV opioid, and you can put that into a long-acting agent. We'll go through an example of this. And you can continue their oral breakthrough at 10 to 20% of their 24-hour opioid total, generally dosed in Q3 to 4-hour intervals. So for example, let's say patient NPO is using 70 milligrams of IV morphine over 24 hours, okay? Going from IV to oral, it's a 1 to 3 conversion, right? So that's 210 milligrams of oral morphine. So we could start 60 milligrams of long-acting morphine every 8 hours. If you wanted to be more conservative, you could have done 45 milligrams every 8 hours. That's reasonable as well. And we'll continue some breakthrough within these parameters at 15 to 30 milligrams of oral morphine every 3 hours. Okay. I know this is a lot of numbers, but they should be in your handout, so if you guys want take time to reflect back on them and chew on them a bit. In the time we have, just a couple of special cases. This may have been talked about yesterday. In patients with renal insufficiency, methadone and fentanyl have no active renally excreted metabolites, so they're thought to be the safest. Hydromorphone does have renally excreted metabolites, but there seems to be better safety data for that versus morphine. Oxycodone is kind of there's not great safety data either way, so it's just to use with caution. Again, this is thinking more when we transition from IV to oral, since there's no IV version of oxycodone. And in general, we want to avoid hydromorphone and codeine-based products. Another question that comes up a lot is, what if a patient's on oral methadone at home, and then they come in with the inability to use their gut? What do we do with that? So one option is to use IV methadone, and it's actually a relatively easy conversion. IV methadone is twice as potent as oral methadone, so you can just cut the dose in half. So if they're on 10 milligrams of oral methadone every 8 hours. At home, you can do 5 milligrams IV every 8 hours. The one thing I'd just say about that is IV methadone has a preservative in it that also prolongs the QT in addition to methadone itself. So you have to follow the QT a little bit more closely in that setting, again, depending on goals of care, et cetera. So last slide here is just about opioid-induced neurotoxicity, because with high-dose parenteral opioids, you will see this happen, and I think it's just important to think about what you might do in these situations. So when you see delirium, you also want to make sure that it's not just the opioids. People oftentimes have a penchant to blame the opioids, but with our patients being complicated, you want to make sure that there's nothing else going on and think about easily reversible causes. You can think about treating the delirium with neuroleptics. Oftentimes, it's our cue, if it is the opioids, to opioid rotate. Myoclonus is something that you'll also see most commonly with hydromorphone and morphine. The first question when I see this is how bothersome is it to the patient? Because sometimes it's more bothersome to us or the family, and it's not actually bothering the patient. If it is, you can use things like benzodiazepines, baclofen. I generally avoid that because usually at the time we're seeing myoclonus from opioids, we're also seeing other signs of neurotoxicity like delirium, and those agents can make that worse. Usually in that setting, I opioid rotate. And lastly, there's this phenomenon called opioid-induced hyperalgesia, which people are learning more about. It's really come up over the last 10 years or so. It's kind of a hot area of research. And we don't know why it happens, but the idea behind this is that at some point with continued opioid exposure or rapid escalation of opioids, there's a switch that flips and actually sensitizes patients to the effects of opioids, meaning that the threshold to experience pain for a given stimulus is less. And so what can happen is that with each dose of opioid, the patients actually experience worse pain. Usually it's their pain that they're having already gets worse, but sometimes they can develop diffuse body pain and cutaneous allodynia, and that can be hallmarks of that. Some people try in this setting to use IV hydration, thinking that, well, this is an accumulation of neurotoxic metabolites. Perhaps that can dilute this a bit. Generally speaking, the other options are to reduce the opioid. We're using these in patients who usually have an advanced process, and reducing the opioid doesn't make a lot of sense. We'll oftentimes rotate, and we'll usually rotate to agents that have NMDA antagonism, such as methadone. We can also think about adding in ketamine, which blocks the NMDA receptor. The NMDA receptor is thought to play the primary role in opioid-induced hyperalgesia, and that's why we use it in this setting. It doesn't happen a lot, but in our institution, we do see it happen a few times a year. And then the other thing, as I mentioned, you can think about using a non-opioid adjuvant like ketorolac. So again, these are all suggestions. You want to still use tailored judgment and make your adjustments based on what you're seeing in front of you, based on their pain level or side effects. So, thank you.